To kick things off, we're pleased to have Elizabeth Fowler, J.D., Ph.D. from CMMI joining us. This session will be moderated by Clive Fields, MD, who's the founder of Village MD, to dive into the world of primary care innovation and how CMMI is prioritizing primary care within their innovation models.
So, Liz, the first thing I have to say is you've done something different with your hair. So I want to actually introduce Purva Rawal, Chief of Strategy at CMMI, who graciously has stepped in for Liz Fowler today, who is at home feeling kind of miserable and hoping we certainly send her best wishes and hope that she gets better quickly. So, Purva, I'm going to take a couple of minutes here for just a little executive privilege. In the last panel, I heard primary care doctors referred to as point guards and as quarterbacks. And I'll be honest, it started me thinking that I'm not sure that we're the point guard or the quarterback. I actually think we're the left tackle. And I'm going to call Fritz, who may be the only person who's followed NFL football long enough to actually understand why I think primary care doctors are the left tackle. The early 1990s, New York Giants had a linebacker named Lawrence Taylor. And he was a proceduralist. And he actually racked up more tackles, more sacks, more fumbles, more interceptions than any linebacker ever had. And he completely wreaked havoc on quarterbacks throughout the league. And the problem was there'd been no investment in the left tackle being the person who would guard the quarterback from that linebacker. And as the proceduralists generated more and more revenue and more statistics and more influence, people started to invest in left tackles. And left tackles now are one of the most highly paid positions in the NFL. And people like Anthony Munoz are recognized as one of the great players in the NFL. I think we're on the verge of going from the under-recognized left tackle to the left tackle that's recognized as critically important, not just in their own right, but as a counterbalance to the proceduralists like Lawrence Taylor. I want you to know, I just thought of that over the last 5 minutes, so I'm going to have to work on it a little bit. But I am pretty sure that left tackles today are really, really important in the NFL and recognized and paid appropriately. And I'm also pretty sure that as we move forward in an outcome-based reimbursement model that Purva is going to get a chance to talk about, that we're going to continue to see that move in primary care. So thank you for being here today. So Purva, stepping in for Liz Fowler is kind of like, that's a big deal. It's like you've been at CMMI for a while. And I know when people ask me to step in for my partner, Tim Barry, you're not really sure exactly what the audience might be expecting. But you were at Northwestern for a while. And you've been at CMMI for, I think you shared about 8 or 9 years now. No, 2 years. 2 years, excuse me. Like 8 or 9, there you go. And married to a surgeon. So sorry to hear that. But it sounds like you're in your position as chief of strategy at CMMI. You're really taking the mission of CMMI and putting it into practical and concrete programs. I'd love you to start out with on the foundational nature of primary care as we think about some of those and dive into some of those programs.
Yeah, so I'll just start by saying thanks for having me and thanks for being okay with me subbing for Liz. It's hard. It's like you can't really step into her shoes. So I'll do my best. Most of you in the room are familiar with CMMI's new strategy that we launched in October of 2021 when Liz came in and a little over 2 years ago in March of 2021, she said, okay, we've got, a decade of learnings under our belt, many of which happen in the primary care space with our advanced primary care models and our ACO models. And let's take stock of those lessons learned and think about how the Innovation Center can most effectively drive system transformation in a more targeted, harmonized way in this next decade. And coming out of that was a new strategy. It has 5 objectives, but I'll just focus on 2 of them that I think are really core. And explain why we feel like primary care is the foundation of, both our strategy and overall system transformation. And I'll say, oftentimes we explain our focus on primary care by saying we want primary care to be the quarterback of people's care, but I'm going to try this left tackle thing and see how it plays with people. But so the first objective is to drive accountable care. We want 100% of our Medicare fee-for-service beneficiaries in accountable care relationships, the foundation of which is an advanced primary care relationship, whether that's in an advanced primary care practice or in an ACO with advanced primary care practices. And then the second is health equity. And we really cannot achieve and that's a CMS-wide goal, a department-wide goal. It's one of the first strategic pillar for our administrator, Chiquita Brooks-LaSure. And we really view value-based payment as an enabling mechanism and a key mechanism for advancing equity. It's really difficult to do under traditional fee-for-service incentives that, don't necessarily unlock access and redirection of resources to places where we've had historical underinvestments. And so we've already started to design and redesign models to be able to use all of the levers that we have available to us to try to redirect those resources and advance equity, including in our ACO REACH model. I'm happy to talk about that. But those are to me, the two really core pieces of our strategy. And we can't really achieve those objectives and that vision without a stronger primary care system. We can't, work on things like specialty integration, coordination, behavioral health, some of, the other big challenges facing us without us really strengthening primary care as our foundation.
Yeah, so you touched on something. You touched on meeting the needs of the underserved. And the other big topic that came up this morning is around behavioral health. As you think about ACO REACH and how that has been redesigned to meet the needs of the underserved, what are the early learnings or opportunities for improvement as you look at that program?
Yeah, so when I think about our work in the equity space, and this is what I think is just one of the most exciting things about working at the Innovation Center and being able to design models, that you can look across all of the different levers that we have available to us and say, which are the ones that we might be able to pull or test to be able to advance equity. And so payment adjustments, right? That was a big thing that happened in ACO REACH, a first of its kind benchmark adjustment. Now we know that that was a starting point, the concept of using, a blend of ADI and dual status for us to, increase a benchmark. We'll have to see if that increase is meaningful at the provider level, at the ACO level. We'll also see if there's opportunities to make refinements to the indices that we're using and the different ways we're adjusting benchmarks. But that was a starting point. We're using a slightly different combination in our enhancing oncology model. I think you'll see more of that this year. How are we using payment to redirect resources and to increase access to high quality care in underserved areas? Quality measurements, another place. Are we using disparity sensitive quality measures in our models so that we are identifying, first of all, are we working with our provider participants to identify the disparities that are facing the communities that they're serving? Are we using disparity sensitive measures to see if our models are closing those gaps? We're also using health equity plans and requiring health equity plans in our new models. There's a lot there that we're learning from our ACO REACH participants. I think we'll learn a lot from our EOM participants and our new models as well. And that's really helping organizations develop that capability and that capacity to say, what are the needs of the communities that I'm serving? What are those disparities in outcomes, care, and access that people are experiencing in those communities? And then what are the interventions that we've identified to start to close those gaps and then measure our progress? So those are just some of the ways that I think value-based payment and our models in particular can test different ways for us to address equity.
No, I think you answered a lot of questions there. And as we shared just before we started today, I think about a lot of the work that you do as taking an unpredictable economic model and making it predictable. And that predictable model being able to invest in clinical innovation, as opposed to fee-for-service, where in most small practices across the country, the doctor's paid last, and they really can't make any kind of investment in teams or analytics or data or proactive care because they're just not sure exactly who's going to call on the phone on Monday morning and actually schedule an appointment. When we think about the predictability of the models that you've created, there's certain areas that are still somewhat unpredictable. And I think about things like, and this is such a policy wonk kind of place to go, but this is where Liz would kind of go. I think about things like retroactive trend adjustment. I think about risk acuity. I think about things that we as an organization that's absolutely committed to this predictable economic model still experience some unpredictability. And I know my peers in similar businesses and similar models are doing the same. How are you thinking about taking some of that out early enough to allow or to increase participation in outgoing years?
Yeah, I think that's a great question. I'll answer that in two different ways. One, I think across the board, especially in primary care and especially in the ACO world, but across the board, post-pandemic, health systems, providers are under a different kind of financial pressure. And we are hearing more and more for the need for predictability. Mm-hmm. So retro trend adjustment is a good example of something that, folks are saying we need more predictability. Now at the Innovation Center, we have to balance predictability and accuracy and our statutory mandate to stay, at least budget neutral, if not, show savings. And so we have to be able to design our models to be able to meet those parameters. That being said, that's a place where we're having a lot of conversations with providers, with model participants to get their feedback on how do we balance the need for predictability with accuracy, and are there guardrails, are there things that we can put in place so that folks have, again, a little bit more predictability moving forward. So I think that's, when we're thinking about benchmarks and, sort of the financial parameters around models, which this is a wonky crowd, so we can go there. But then I think for primary care in particular, we've learned a lot from, the advanced primary care models that CMMI has tested dating back to 2012, right? With CPC Plus, and now PCF. And we've seen that when practices get more stable upfront revenue, they are able to change the way that they deliver care. We actually put a paper out last August with some, a number of learnings, but that was the first learning, that 5 major learnings that from our previous models that are informing future model development that we put out last year. And that was the first finding, was that when we, use payment in a prospective in a way and provide more stable payments, we can change care delivery. And so I think that to me is one of the really key pieces of what we're working on at the Innovation Center across our portfolio for primary care, is how do we create and how do we help and support more practices in A, increasing investment in primary care, but B, moving to more prospective, stable payments and revenue so that they're not subject to those revenue fluctuations like we saw during COVID.
Yeah, it's the predictability of an economic model. Again, I truly believe allows for investment and innovation. The other hot topic that I mentioned that continues to come up is the area of behavioral health. And I continue to be amazed by the people who think that behavioral health access and issues can be fixed without a focus on primary care. As a primary care physician, I'm going to say half of the patients I saw presented with a primary or a secondary reason that was in the behavioral health arena. As you think about programs that will actually bring primary and behavioral health to a singular spot, people talk a lot about parity between primary care and mental health, but then they want to actually have different doctors that take care of it. It's a little bit strange. How are you thinking about program design and bringing those two things together and really leveraging the hundreds of thousands of trained primary care physicians who could extend their capabilities in the behavioral health arena?
Yeah, so I'm a psychologist by training, and so I completely understand, totally understand what you're saying in terms of patients don't present to the specialty or the provider that, you might go to your primary care physician, but you have underlying depression or anxiety, or you're not necessarily going to go first to the psychologist, psychiatrist. You're going to present first to primary care. We, again, have had a long history in our primary care models of testing different facets of behavioral health integration to varying levels of success. But we've had a lot of learnings there. And so that's a huge area of focus for us, is how are we thinking all the different ways that we're thinking of behavioral health integration. It's not going to be a single solution. So, we're thinking about what comes next in the primary care space, primary care model space for us. We've been thinking a lot about behavioral health integration, but in a progressive way. So when you have practices that might be newer to value, safety net providers, they may not have the care delivery infrastructure, the capability, the team-based infrastructure yet to really address folks' behavioral health needs. But how are we supporting practices in increasing their ability to address behavioral health care all the way up to behavioral health integration? So again, it's building blocks and making sure we're giving people the upfront support that they need, and then moving them again to those more stable revenue structures that allow them to integrate key members of the team that can help address behavioral health issues. We can use quality measures also to start to move in that direction. And then we're also thinking about future models in the behavioral health space that focus on community-based behavioral health providers, because we've never had a model targeting community-based behavioral health providers. So we know that, I think of it personally as like a no wrong door approach, that if we want to if the more providers that we get into value-based payment and the more that we're connecting providers across settings, we'll be able to meet the needs of beneficiaries so they don't present anywhere where their needs aren't met. And so we're also thinking about what we can do in the community behavioral health space. And there we know oftentimes, and as a former psychologist, I had a lot of patients that had a number of chronic disease issues, but their primary issue, they had moderate to severe behavioral health issues in many cases. They were presenting first in the psych ER or in in one of our outpatient psychiatric clinics at Northwestern. But their physical health needs weren't being made. Their medical needs weren't being met. And so one of the things we need to do was connect folks back to a primary care doctor, make sure that their, hypertension, diabetes, et cetera, those things were also being taken care of. And so I think we need to create more of those bidirectional linkages and making sure, again, no matter where someone is presenting, we've set up the incentives in the system for their needs to be met.
I practiced medicine long enough ago that the most common diagnosis of the day was fatigue, because depression and anxiety wasn't covered in a health benefit. But what I'm always struck by is the need for collaboration in the behavioral health arena. People talk about collaboration. I'll be honest, when I heard first about the collaborative care model, I said, well, of course we collaborate with psychiatrists and psychologists. We collaborate with nephrologists and cardiologists and orthopedists. But when you dig into models like the collaborative care model, for most primary care practices, what that looks like is fixed expense and variable revenue. In other words, the cost of my affiliated behavioralists will go up every year, and the reimbursement for that work will go down every year. So why would I launch a business line or a service line that ultimately will lead to economic failure? And I think about that in the models that you design, and the need for you as a psychologist many times to use me as a primary care physician to access medications that your license may allow you to prescribe, and certainly for you to prescribe therapy or perform therapy in a way that I can't. Behavioralists continue to kind of live in this separate world, and we continue to actually create models that almost create, again, community-based behavioral health models. And I just wonder if there isn't a way for CMMI in the area of innovation to actually bring those two worlds together with the kind of predictable economics and investment in innovation that your current programs do, recognizing the difficulty of bringing those two worlds together.
No, I think you're exactly right. And when I'm talking about bringing more community-based behavioral health providers or targeting efforts there, it's because they are, they've never had the opportunity to participate in a value-based payment model, right? We don't have the quality measures in that space. We haven't even, given that they don't have the health IT infrastructure that the rest of the medical system does. And so if we really want that collaboration, we're going to also, I think, need efforts that focus on bringing those community health providers into the fold and then using the model to create those linkages and support those collaborations back into primary care. So I completely agree with you. The economics have to be able to support, and the health IT infrastructure, the data infrastructure has to be able to support that kind of collaboration, which right now, most of our energy has been focused really on the medical side of things, right? And so we've got to, I think, kind of grow the tent and bring more people in and bring more of those providers in so that we're using all of the access points that we have out in the community, if that makes sense.
No, it does make sense. So I'm going to pivot a little bit to two areas that are greatly impacted by and through primary care, but not exactly primary care. And that's the area of drug costs and specialty utilization. It is almost impossible in an organization like ours that takes global risk in our Medicare population through the ACO REACH program to get a handle on the just incredible rate of rise of drug costs and the rate of rise of specialty service, both utilization and unit cost. How is CMMI thinking about improving or enhancing the opportunity for success in primary care through programs that engage those two particular areas?
I think it's a great question. On the drug cost side, I will say the president signed an executive order last October directing the Innovation Center to come up with model concepts that the secretary would then choose for us to test. And obviously IRA had just passed. And so, we were starting to think, okay, there's a number of changes, historic changes that CMS is implementing as a result of the Inflation Reduction Act. We need those changes to go into place. I think they're going to make a huge difference in the lives of millions of beneficiaries out there. But there are continued challenges. And so our team at the Innovation Center was really charged with taking a step back and saying, here are the changes that are going to be implemented as a result of IRA. What's left? Where else can the Innovation Center play a role in addressing access and affordability? And that was really the charge: access to novel therapies and affordability of drugs. And what we did is released a report, I think it was on Valentine's Day, and in February of this year, detailing 3 model concepts and a few additional areas for research for us to start to engage on more detailed model development. And I can talk about a couple of those here. And honestly, we would love to engage with primary care providers and the community here to get thoughts on these models. They're early in development, so this is a great time for folks to weigh in and tell us what would be helpful, and especially as we structure these model tests. The first one we're really excited about is the high value drug list, or the $2 drug list model test, where we want to be able to create a standardized drug list with for 100 up to about 150 different generic drugs that would be offered in Part D plans at a copay of $2 or less. And so here, what we want to be able to do is use standardization to drive access and affordability. We think this is going to obviously be helpful to Medicare beneficiaries right now, where their plans, their copays are going to be different. The generics that might be covered are going to be different. There isn't a standard list. We also think this is going to be helpful to providers who often don't have that kind of visibility or transparency. And by creating that standardization, we're hoping that really helps, especially in the chronic disease area, both primary care providers, and patients. The second model is our cell and gene therapy access model. We know there's so much innovation going on in the cell and gene therapy space, but these drugs, or these therapies, I shouldn't call them drugs, these novel therapies often are coming with price tags of $1 million or more. There are a number, I'm sure everyone here is familiar with the numbers in terms of what's in the pipeline. Here, the model is really focused on Medicaid to begin with. We know that Medicaid programs in particular are, already under stress from some of the CGTs that are coming online, and we anticipate that challenge is only going to grow. And given the financial challenges, that means we're going to have inequities in access and long-term financing challenges. And so we have started development on a model that would provide states the option for CMS to negotiate outcomes-based agreements with manufacturers for cell and gene therapies, in hopes that this helps us understand, give us some solutions and test some ways to think about long-term financing, testing out outcomes-based arrangements, or OBAs, and also looking at the impacts on equity and access in Medicaid specifically. And then the third is an idea around accelerated approval drugs, or accelerating clinical evidence model, where we're working closely in consultation with the FDA to say, are there payment adjustments or other levers that we have available from a CMS or CMMI perspective to increase evidence generation on accelerated approval drugs. And that's one where we know FDA also has some new regulatory authority. So we're working with our colleagues there and seeing what might be possible.
The second part of that question was around specialty care, because I see a lot of CMMI models that it might be orthopedic bundles or in the oncology arena. For those of you who've been challenged to find a primary care doctor on Friday afternoon, good luck finding an orthopedist or an oncologist. So it does feel like those models, when tied to a primary care delivery system, or with primary care, both incentives and work to be done, would be more successful. But it looks like we continue to silo that work. And I know working in Houston, we work with an incredibly comprehensive oncology group. But they're not really there to manage the behavioral health needs of those oncology patients, the associated but not directly related complaints related to oncology, the trips to the emergency room or the urgent care for simple hydration. Thinking at all about how you bring some of your specialty models closer to primary care, or ask primary care to move closer to the specialty models.
Yeah, this is a huge tension that I think we have to balance, especially, and I talked at the beginning about our accountable care goals and our equity goals. I don't think we can deliver truly accountable care if we're not meeting people's primary and specialty needs. And that means a different way of collaborating, coordinating, integrating. Everybody wants to use a different word. And there's, all those terms have different, levels of, collaboration. We had a specialty strategy that we released last fall that kind of has 4 parts to it. And it starts to lay out how we are thinking about advancing accountable care, again, through advanced primary care and ACOs, while also meeting people's specialty needs. And has kind of 4 prongs, and I'll talk about that. And this is another place where we're looking for public input, folks' thoughts, especially, I think we're going to learn a lot from our REACH ACOs about how they are doing this. And I think that's going to inform a lot of our future work as well. But the first is data and transparency on, on specialists and specialist performance. And so we're looking at, some options to do data specialty like profiling, helping inform maybe, referrals from primary care physicians to local specialists. We're also thinking about data sharing back to ACOs. So we actually just completed a survey of a number of shared savings program and reach ACOs on the use of shadow bundles. What happens when we're able to deploy data back to ACOs that they may not have right now? Does that help them either work with a different set of specialists? Does it help manage specialty spend in a different way? That's going to be a place where we're going to be looking for a lot of feedback. We're also looking to release a request for information, an RFI, on some of the components of our specialty strategy, and in particular, where do we go next with our episode-based payment models so that they are more aligned with a longer-term primary care-based and ACO strategy. So as you said, we've had a number of bundled payment models that we've also been testing dating back to the beginning of the Innovation Center. We've learned a lot. They've historically been 90-day bundles. And we know that can sometimes create conflict between, who are the episode initiators and the ACOs. So we're looking at, options like a shorter bundle, for instance. Like how do we bring more health systems, hospitals, specialty physician group practices into the kind of the value-based payment arena while really pushing the, care and longer term care and the population health components back to primary care and ACOs. And then this is a little bit further out, but as we get further into the accountable care strategy, are there other arrangements that we might be able to identify longer term, condition management? How do we support or create test models that allow for co-management in some cases between primary care and specialty care? So it's a multi-pronged strategy. I think that's probably a theme you're hearing from me, that there isn't a single model, whether it comes to primary care, specialty care, behavioral health, that's going to solve for all of these problems. And so we're taking a cross-portfolio view and really looking at, when we're thinking about a new model, what can we embed into that model to achieve, some of these, to address some of these challenges.
Now, a couple of times you've mentioned data, and CMI is clearly a data-driven organization. The challenge with data is the amount of time it takes to collect it, the amount of time it takes to analyze it, the amount of time it takes to act on it. With organizations like ours and many of the others in this audience, having to actually make very quick decisions about where we invest, where we focus, and where we actually do our work. How are you thinking about shortening the time between knowing there's a problem and affecting a solution? And I think about that again in the areas of retro trend. I think about in the areas of program discounts. I think about that in other benchmark areas where you kind of have a sense there might be an issue, but the patient can't wait 2 or 3 years for a solution.
Yeah, so I think there's a couple of different layers of data. There's the data that we often take in from our participants. There's the data that we are providing to our participants, and there's kind of the financial parameters and the program level data. And so I'll just say that the communications that we get from our model participants are really important. Oftentimes they are early indicators for us, right? We might be seeing something in the data, but then having folks come in and talk to us and tell us what they're actually seeing on the ground, immensely helpful because it tells us where we might be able to dig in deeper. I think there's also volatility often in the data that does, over the course of a year, balance out. And so sometimes it just takes a little bit of time, and not all organizations are the same. So oftentimes we have to make changes and make a set of decisions that would benefit the program, the model as a whole, and as many participants as possible, knowing that everyone's economics and business models are a little bit different. When it comes to communications with our participants, we often have model-specific portals, dashboards, and data feeds, and that's a place where we are, looking to make improvements. We've, have in the primary care space with both CPC Plus and PCF, we've had, made changes to some of the dashboards and the data capabilities in terms of what we're feeding to our providers. That's an area we are very focused. We think there's opportunity for continual improvement to close that gap between the data and what's happening at the point of care. And then there's the data that we are taking in from our participants. And so one example here, ACO Reach is the first one, EOM will be doing the same, is collecting self-reported demographic data for participants, which we think is really core to, we can't effectively design health equity related interventions and achieve those goals if we don't have accurate data But there, we're hearing about a lot of challenges out there that folks are having in terms of reporting, submitting those data. And so we're looking at, different capabilities and problem solving. It's, not always the easiest road for many of our model participants because they are sometimes the first movers. Mm-hmm. And so we're testing new things out and often finding out what's working and what's not, but problem solving with them kind of in real time as well.
Well, I will share with you that our team in particular is incredibly pleased with the frequency, the quantity, and the quality of the reports that you put out now as opposed to a year ago. So thank you for taking that feedback from folks who really are looking.
Saying something nice because we always hear that on the data front.
No, the answer is I recognize how difficult the challenges are that you have, but that's one of those that we brought to CMMI, and CMMI has responded in an incredibly positive way. So Purva, I'm going to take you a little bit out of the CMMI role and bring you back into kind of the bigger public policy issues, which are affecting the success of the programs inside the Innovation Center. And those are in the area of things like workforce challenges that have been brought up today, site of service payment inaccuracies or discrepancies, 340B programs, things that aren't really in your bailiwick, but in all honesty are greatly impacting organizations that are trying to be successful inside innovation. How much impact or sharing goes on across this huge city that we're in today and across the myriad of responsibilities where you can share with your colleagues in government that workforce issues, 340B, site of service discrepancies are actually impacting your ability to drive higher quality, lower cost programs? Or are those also siloed solutions that don't ever either receive or take input from CMMI?
Yeah, I think I'll take the workforce issue first because that's one that I would say in all of the site visits that we're doing, speaking engagements, meetings, workforce is probably one of the top two issues that we are hearing about. Historically, I don't think it's a place where we've thought as intentionally, maybe not intentionally, but it hasn't really been the focus of a CMMI model to do something about workforce, right? Given what our mandate is. But I think it's becoming increasingly clear to us that similar to equity, we probably have some levers available to us in our models to be able to better support workforce, the healthcare workforce. And there are a lot of resources across the department, as like Judy knows, that where we can be working more closely with our colleagues in HRSA and in other parts of the agency so that we're leveraging all of those resources, making them available, connecting the dots, across these different programs and funding streams. I will also go back to your question originally about one of your first questions around economics. And I think in primary care, this is especially important, that if we can create more stable economics and a more stable revenue structure, that hopefully supports providers better in their work. So we're really focused on, patient experience, obviously. But one of the questions we're also asking is how are our models better supporting providers in the work that they're doing? It's actually a question I asked at a number of ACO REACH site visits that I was able to join our team on last year. I was asking providers that are in those models, just anecdotally, is this changing anything for you day to day relative to how you were practicing 2 or 3 years ago? So I think that's something we can tap into a lot more systematically and really understand that payment's not the end to answer. The payment is the mechanism for a delivery system that's more effective for providers and for patients.
So I'm going to ask for you to give Sean kind of a Twitter headline here. What do we see? What do we see in the future? What can you share with us that's coming down the road?
Yeah, this is a question that we're getting a lot, our goal this year is to announce three to four models. I think everyone's been waiting for us to, where's the Innovation Center heading next? We've talked to a lot of you in the room already. It takes 18 to 36 months to design a model, and we kicked off our new strategy just about 18 months ago. So, stay tuned. We are definitely, given the heart of the strategy around accountable care and equity, I think early on between the Enhancing Oncology model, the changes we made to ACO REACH, I think gives you a nice blueprint for how we are going to approach model design. We have a huge focus on increasing safety net provider participation in our models, FQHCs. So we're hopefully in the near future we'll be able to, announce a new advanced primary care model that's really focused on equity, increasing safety net participation, supporting more providers and entering value-based agreements. we're also thinking about, from a primary care perspective, a little over a year ago, we also released a paper with our colleagues in the Center for Medicare and the Shared Savings Program, but really using the Shared Savings Program as a chassis for innovation. So we're thinking about future ACO model opportunities as well that, again, strengthen primary care, move to hybrid payment models, increase investments in primary care. We also have more coming in the specialty space. There are some areas where ACOs right now are not in the best position to take care of certain specialty conditions. So we're going to continue to look at some specialty-specific models that hopefully test new care delivery pathways that can be scaled into global total cost of care approaches as well. Dementia is one space in particular that we're really interested in, and it's a priority for the administrator and CMS. So just some thoughts, but hopefully a lot to come this year, and a lot of the topics that we covered.
Then my last question is really an offer from the PrimaryCare for America Coalition, from our coalition partners. What can we do to help you advance your projects?
I mean, there's continued dialogue. We really appreciate it. Tell us what's working, what's not working. And really, especially when it comes to primary care, there are a large percent of providers that, are still operating in fee-for-service. And just from my previous work, oftentimes the word value doesn't resonate, right? People providers they often view that as a return to managed care in the 90s. I think the more that we can do as a community, the more that you all can do to educate folks about the importance and the opportunity that value-based arrangements and value-based care can help them in terms of meeting, whole person, meeting the full needs of their patients, supporting team-based care, addressing burnout in workforce. I think, creating that kind of enthusiasm and showing people that there's an opportunity here to not only serve their communities better, but to do it in a way that's more sustainable for them, I think would be great. And honestly, your continued, feedback and engagement is welcome and helpful.
Yeah, well, Purva, thank you so much for your participation today on relatively short notice. It was a real pleasure.
Thank you.